we've done concussion or post-traumatic headache this is our second year, and each time we get a speaker for this, somehow they don't make it here. So today our speaker did not make it, so I'm very good friends with Burt Vargas, and he's given me his slides. I started stalking him about 10 years ago when I saw his concussion work. He does great work, so today I'm going to be Burt Vargas. I'm a doctor now. I'm a doctor at UT Southwestern Medical. I actually graduated. I went to I worked at the Mayo Clinic, right, with David Dodick. Yes, but Burt Vargas is great, and he works at UT Southwestern with like Deb Friedman and a lot of people, and he's actually on the sidelines. So let me see, where's the clicker? So I have not reviewed my slides in about 5 years, but Burt has done such a great job of dumbing this down for people like me that I feel very confident and secure that we can manage. So I just want you guys to be here in case I mess up some of the statistics, okay? All right. We actually fought over who got to do this, and I won. These are my disclosures. And I get to, this is Burt on the far left. He gets to be with the team all the time. He gets to be in the action. So if somebody gets hit in the head in a football game, I hear that's what they do sometimes, he gets to be there to decide whether or not they're going to leave that player in or out. I never get that option. Do you get to be there when somebody's actually getting hit? Do you do athletic stuff?
I'm not, but I've heard about it.
Okay, but I mean, that's really an honor that a lot of us, we don't ever get, because of it. You did? Yeah, he likes sports. That's why his name's Bake. And so when we're learning about how to treat post-concussive headache, unfortunately, Dr. Undesser, he works at the VA with veterans, but by the time they get to him, they probably got hit in another country, and so it's not right after the event, correct? Same here. By the time I get sometimes I get somebody who might be a cheerleader or a soccer player, and she has 25 concussions, and they're like, and mom really wants her to be Ole Miss cheerleader, so they keep on letting her do all these tumbles and all these falls. But if they fall or have something significant happen, like at the gymnasium or somewhere, they typically go to the ER to get their to look for a skull fracture first or a bleed, and then get that ruled out. But then nobody really tells them what to expect, and then that's when all the problems happen. So I'm going to try to tell you what to expect. Okay, what % of your practice involves management of patients with concussion? Well, I talked about ours. Anybody deal with a lot of concussion besides you, Dr. Undesser? Okay, good. Let me see. By definition, concussion requires a direct trauma to the head with at least a brief loss of consciousness. That's false. You're right. Who said it? It's false. Yes. I learned this from Burt, that it's a blunt force that basically jars the brain, and that force could come from your feet. So if you got hit very hard on your feet, it could actually cause a concussion up here. So he describes it much more eloquently. Concussion facts, that looks like a brain. Okay. A concussion is traumatic brain injury that may be caused by a blow to the head, neck, or face, or anywhere else in the body with an impulsive force transmitted to the brain. So,
Christine, I'm going to interject
yes.
because that's an old slide.
Thank you, God.
It is an old slide. And this is the way we used to, if you're going to go back to that.
Okay, yes.
That's the way we used to think that concussion occurred, is that it was the brain banging inside the skull. The reality is there's really not that much room, and it's a lot of padding. That's not how concussion occurs. What occurs is there are forces, as in it's mostly rotational forces, that cause the brain to twist and turn on itself. And there have models been built based on gyrometers and other measuring devices in helmets of football players, and after they didn't need that much data, they were able to build a model which showed that as the brain twists and turns on itself, the majority of the force is along the corpus callosum, which is the part connecting the right and left side of the brain. That's how the right and left side of the brain talk to each other. And we know in CTE that most of the lesions found are in the corpus callosum, which goes along with the current thought. It's this rotational. Getting hit head first straight on is the least damaging. Getting hit from the side is the most damaging. So the more rotation there is to your head, the more rotation there's going to be to the brain. In blast injuries, it does the same thing. And I've seen a lot of people from military that have been involved in blast injuries, and it causes a vibration, a rotation of the brain inside the skull. You don't even a lot of soldiers have felt that. If they're in the range that they can feel the blast with their body, then their brains have been shaken. So you don't have to be hit in the head at all. All you need to do is have your head forcefully rotated quickly, and the brain twists and turns, and the connections in the corpus callosum are destroyed. There's the connections between the cerebellum and the rest of the brain that are injured. It's mostly an injury to communication tracts in the brain.
I would second that, by the way, Nate. And as a matter of fact, I've heard a very interesting story from a retired Marine captain who came to see me with post-traumatic headaches. And I asked him, did you have any direct head injuries? And he said, no, I was in Afghanistan for 2 years. I was in Iraq for 2.5 years. Never had a direct injury, but I had a lot of blast injuries. And I said, how frequent do you think it is in those theaters? And he said, if you're in Afghanistan, even if you spent your whole time in your office, you had exposure to a blast injury. And he said almost everybody that he knew there had post-traumatic headaches. So you're absolutely right. It doesn't have to be a direct injury. You don't have to compress your brain against the skull. It's rotational forces and changes in pressure that probably play a big role.
And we know, and you're going to probably get into the
Actually, I'm going to have you come over here now. Yeah. We're trading places. You're going to be here.
Oh, I'm going to be there.
Yes.
Okay.
Come over here.
Okay.
We got it. Okay.
What is CTE used abbreviation?
It's chronic traumatic encephalopathy.
It's over there somewhere.
You're going to hear that a lot. Do I get this too?
Yes, you get that too.
Oh, I don't get a. Okay.
You get the clicker. You got the clicker?
I got the clicker.
Okay, wait. I'm going to get this. Okay.
Well, Christina has gone through these slides. I haven't seen them yet.
10 years
Because we're
ago.
going to probably talk more about the symptoms of concussion also. And many people, many of the soldiers who have the blast injuries are being diagnosed with post-traumatic stress disorder. And it was about 2 years ago, I was reading an article that said that the symptoms of post-traumatic stress disorder mimic the symptoms of post-concussive disorder. And I said that's because it is post-concussive disorder, and they're being misdiagnosed. There's a lot of other things that occur. But let's see what the slides have for us today. And it's not, there we go. As I said, it does not require loss of consciousness, does not require direct contact of the head, and we don't grade them anymore. Those grading systems were all based on loss of consciousness, and we know that people with mild traumatic brain injuries are more likely to have long-term symptoms than people who have moderate to severe. So it really doesn't matter anymore about the loss of consciousness. It does, but as long as short period of time. What matters is what happens afterwards. What is the response of the brain afterwards? What are the symptoms the person have afterwards? Let me read says up to 50% of playing collision sports have concussion symptoms and only 10% report them. Here's the thing that's scary, and I've heard, you look at these concussion data, football versus hockey, women versus men, we know two things. First of all, women are twice as likely to be concussed than men are. The threshold's lower. People with migraine are more likely to be concussed than people without migraine. So there is something different about the brains of these people that lower their threshold. When you're talking about football, it's the only sport that on a play-to-play basis, there is trauma to the brain. The players, especially on the line, are colliding with each other every play. So I call them, every play, there's at least 20 players on the field who get microconcussed. There are plenty of people with CTE, chronic traumatic encephalopathy, who have never had or have never reported a frank concussion. And they're following this in the NFL now. Which, by the way, I blame the NFL for not being so far behind in concussion, because they knew about this back in the 1970s and didn't do anything about it. In the general public, these are, and I don't know what year these data are, you can take a look. Most of these are from falls, motor vehicle accidents. Anyone that has whiplash by definition has traumatic brain injury. There's no way you can be whiplashed and your brain not be traumatized. Some people get lucky and have very little symptoms, but how many people have continued symptoms after that? This is one underreported, underdiagnosed. We're getting better at this, but we're still seeing a lot of, and you guys can chime in too, a lot of people that are not being diagnosed. And a lot of it has to do because it's history and it's exam, and they're not going to do it on the field. One of the biggest disservices I saw to the United States is at the game, the Steelers were playing and their new quarterback got knocked out. He got up and walked off the field, which I felt like running down onto the field, because I think the physician who gave the clearance for him to walk off the field should be fired. That's malpractice. If someone gets knocked out, you have to be very careful. You don't know what happened to their neck. So people are, that kind of thing makes it look like it's not that big of a deal. It's a big deal, and we need to pay attention to this more and getting this diagnosed. There's still a lot of football coaches out there that think that this, I got my bell rung, I can get back up and play. So it's very important to identify this. So anybody, and athletes won't say anything, even high school athletes. Who I had a patient a couple weeks ago that was playing soccer. She didn't know what the heck was going on during the game, but she wasn't going to tell anybody. They didn't find out until a couple days later when her headaches got bad. Go ahead.
For a second. I used to coach youth hockey quite a few years ago. Plus, I played myself, and I actually used to see patients who played for one of our local professional hockey teams and several of the college teams in the area. They all stopped sending me patients. Why? Because I was diagnosing them as having what we called then a concussion, but now we would call a mild traumatic brain injury, and insisting that they stay out of competition until they were totally symptom-free, particularly headache-free, for a minimum of 2 weeks. And it was shocking how, over a period of 3 years, I went from seeing tons of these kids, literally kids, even the professional hockey players, who, by the way, are a lot crazier than football players. The coaches and the organizations just didn't want to hear it. So what you're saying about the NFL is true even at the college level and in other sports as well.
I just noticed that Christina took off. All right. Better question. Which of these is not a symptom of concussion? All of them are symptoms of concussion. And we need to recognize that there are so many things that go on in destruction of these tracks, and people have memory problems and headache. A lot of times they may not feel something right away. And it may just hurt a little bit where they got hit or from their neck, but these symptoms progress. And I don't know, In general, it's thought that if the symptoms occur within 2 weeks of the concussion, then it can be attributed to the concussion. But I can't tell you how many times I've seen people that had no headaches whatsoever, didn't fit the phenotype for migraine, and 6 weeks after a traumatic brain injury started having problems. Why? I don't know.
There actually may be a physiological reason for it, and it's called kindling. And having started out actually in epilepsy before I got into headache, we were able to demonstrate and use it as an experimental model of acquired epilepsy, where you give a subthreshold stimulus once a day for a very brief time to particularly, usually around the amygdala or other areas in the temporal lobe, and after a few days or weeks, depending on the animal, you start to get an electrical discharge spontaneously without it, and then the animal would very often have full-blown seizures that look like complex partial seizures. Turned out not to be that great of a model for testing drugs for epilepsy, but it actually is a very good model for learning on the cellular level. And I think that's part of how migraine and other post-traumatic headache disorders become a learned phenomenon. I'm not talking about consciously learning, but the cells learning and propagating these signals that result in headaches occurring in these patients.
You know, that was always what I thought theoretically, but I didn't know there was a name to it, there was anything behind it.
But it's also important that there is a timeline, that you should be within, whether it should be 2 weeks or 2 months, it has been heavily debated, yeah. But it's not 5 years, because all our migraine patients, all our headache patients had a head trauma sometimes in the childhood, and they say, oh, I had this 10 years ago, could it be the reason? And it's also important, every adult person every child had a minor head trauma. Otherwise, they don't live. So it's also important that to cut. It's not because of that. And many parents, they feel a lot of guilt because they lost the baby or whatever they did, and so it's important to have a timeline, also for legal issues.
Absolutely, but
what is the timeline?
Yeah,
We don't know.
Yeah,
that we don't know.
But it's important to have the physiology behind it. But it's also important for also the patient, and also that we have an explanation for.
Yeah, one of the problems that we all have is when did the actual headache disorder begin? Because it's all based on history, and a lot of times, especially with athletes, I find this, they are very much in denial about how often they're having headaches or when they first begin. So it's really helpful to have some unbiased person who can say, yeah, I remember you were getting headaches within 2 weeks after that injury. They were intermittent, and now they're there all the time. I hear this on a fairly regular basis, mainly because I don't see them acutely anymore. I usually see them months or even years after it started, and it's like pulling teeth to get the history out of these patients. I agree with you completely.
So here's a list of the different symptoms. And it's not a small list. So it's important to get a history. Now you have to realize that if you've got somebody with migraine, that a lot of these symptoms overlap with migraine too. And knowing that people with migraine have a lower concussion threshold, this can trigger off a whole different event. Now, we talk about, there's some people that go on to have continued headache despite the other symptoms resolving, and we still technically call it a secondary headache because it didn't start until the person was had the brain injury. But sometimes I wonder if it takes on its own life and becomes its own primary headache. But these are very, very common symptoms, and one they don't put up here, they don't point out, is pseudobulbar affect, which in some of the studies show up to over 50% of people have pseudobulbar affect. Pseudobulbar affect is when the person has emotions that are incongruent with what they're feeling.
crying when they're not sad, laughing when they're not happy or it's not funny. And that's by definition. They don't talk about emotional outbursts. I've had a lot of people with PBA after traumatic brain injury who were lashing out and yelling, and they said, I wasn't even angry, I don't know why I was doing it. They lost control of it. People that are talking to somebody out of the blue start to cry. That's pseudobulbar affect. It's considered, a lot of people think of it as emotional, but it's really more of the cognitive. It has to do with between the frontal lobe, the pons, and the cerebellum, the disconnect in controlling the emotions. So a lot of uncontrolled emotional outbursts are part of this also. Let's see. This is what we know, and I can say, obviously the headache prevalence is pretty high. I don't know if he talks about, let's see. Now here you'll see it says within 7 days. We already talked about this. The most common phenotype headache is migraine. Now apparently there's others. I don't know if you've seen anything else. Almost everybody that I see with post-concussive headache is migraine. What do you?
Mixture. It's a mix.
Yeah.
They have this constant background headache that could feel the criteria of attentive type headache, and then once in a while they have the migraine on top of that. But they have this background. I can treat the migraines, but I cannot treat the background headache, and it's there all the time. It's bothering more than the migraines because they come once a week or twice a month or something like that. But the other is there 24/7, and I cannot treat that one, and that's the bothersome. In most of my patients that come to it.
It also tends to be holocephalic. It's a dull holocephalic constant, no matter what they do. So it's the whole head, poorly localized, not typically throbbing, at least in my experience, and it just seems to just be that. Pressure is a word that patients use a lot, or they'll say things like, I can feel my brain move in my head when I step, so.
And neck pain plays a role in that.
Yeah, I may be seeing a slightly different population than what you're seeing, because almost everybody who comes to me is referred to me is because they have migraine-like headaches. But a lot of these post-traumatic headaches like you described, especially the ones that do have some headache-free intervals, even if they're minimal, they very much sound to me like chronic migraine, and I often treat them as chronic migraine patients. And we've had some pretty good results using botulinum toxin and the CGRP monoclonal antibodies on these patients. But there's a subset of them, just like you mentioned, that never have even a minute where they're headache free. And after listening to the talk on CFF leaks yesterday, I'm just wondering how many of them all of us are missing.
And Ian's not here.
Yeah, I don't know.
Ian, he didn't. Dr. Carroll didn't talk about that, but I've talked to him about that. That there's probably spontaneous leaks in a lot of these people from in the neck region from the whiplash.
Yeah. And I wonder how many of them, especially ones who have anterior facial injuries, may have some subtle leaks around the cribriform plates that are very difficult, to diagnose, and perhaps even a lot more difficult to seal those if they do have a leak from there.
But their headaches are not positional, these patients. And the majority of them, they feel better when they lie down because of they have not all the visual symptoms. They can relax a little bit, but the headache is the same. It's not a typical orthostatic headache, I feel, because it has been described for 10 years, 15 years by the Japanese, the Asian groups, that it is related to trauma. But I always ask them, it's not this positional, it's not so clear a picture, but maybe there's subgroups that we have to work on. But maybe we should ask more carefully after this. So I learned a lot.
And I agree with you, because most of them don't have a positional quality to it. When we see them, which could be several years after they had it. And going back to what it was like at the beginning, they often don't remember. And you know, sometimes, again, having a good eyewitness account of what they were like immediately after the injury might be useful. You know, some family member or a coach or especially from the military, some of their buddies, they might be able to tell you what they were like, whether they were always laying down to get rid of their headache or not.
I have had some success with ketamine in people with post-traumatic headache that I don't have any control. The problem is that they are so sensitive to trauma to the brain, is that any little hit to the head and there it goes. It's off and flying again. So let's see what else we have in store. There, the difference between mild and moderate trauma. And this is what we were just talking about, the persistent headache. It's hard giving a talk without ever seeing these slides, but I think our discussions have covered most of this. Here, delayed onset post-traumatic headache, 23% of headache within 3 months. 19% of soldiers with headache 7 to 30 days after injury. So there goes what we were talking about before, is 3 months may not be that far out. 2 years, I don't think so. But
1 year. If it isn't better after 1 year, there's a declining curve for a huge population, that it goes down within the first 3 months and then it's down to 1 year. If it's not done after 1 year, it's more persistent. So 1 year is a cutoff.
Okay.
In most of the literature, yeah.
And we already covered this. Has anyone seen paroxysmal hemicrania afterwards?
I've seen paroxysmal hemicrania, and I've seen hemicrania continuo after it as well.
I see that some of
Microphone.
the cluster headache patients that say, they had this, but it's difficult to hang exactly. It's months after they had a head trauma, and it could be years after. But patients and relatives, they want to hang something. The cause, it was because that 2 years ago you had this
Right.
traffic accident. I'm not sure. There are a few cases that it's very close temporal relationship to a trauma. And of course it has legacy issues, but the majority, I can't find it. So cluster headache, but migraine-like and tension type-like, it's the normal one.
And here's the data on the phenotype of what these headaches look like.
Yeah, and usually it's a combination. It's not either or, it's a combination, but it's easy to put one label on instead of have two.
I have to wonder about cervicogenic, because by definition, cervicogenic headache requires a lesion in the cervical spine, or it's a lesion somewhere. And I think there's a lot of people that have injuries to their neck, but the neck and the pain centers of the brain are bidirectional communication, and we know that 75% of people with migraine have neck pain, and treating the neck will help migraine, which chiropractors live on that because they treat the neck pain and the headaches get better, so therefore it's your neck problem. But that's not necessarily true. Though a lot of people, because of the concussion, are going to have neck injuries, and you have to treat the neck injury also, or that will continue the feedback and continue the headache going also. One thing, we're still talking about headache, but one thing we haven't talked about is physical exam, because this is where I find that a lot of people miss this. Here's their prognosis. I mean, I've heard, and I don't know how much scientific evidence there is behind this, but in general is that if they're not better within the first few weeks, that at least half of them will be better at 6 months, another half will be better at 1 year, another half will be better at 18 months, and half of those would be better at 24 months, and after that it's a crapshoot. And I don't know how, I've heard it many, many lectures. I'm not sure how much scientific evidence there is for that. And then we talked about all this already.
The old studies it's not plus minus headache, because they also had headache before. You have to quantify it. Is a daily headache, it's highly disabling, it's once a week, or is it once a month? But it's not just plus minus, because the frequency goes down, the intensity goes down by time. So having a headache 2 years after, it doesn't mean that it's a disabling headache. And these old studies, it has not been quantified. It's just black and white and plus minus. So we have to quantify it and put the proper description in
Well,
it.
there are also studies showing that the average length of time of a post-traumatic headache is 5 years.
Yeah.
And some people, other symptoms are gone before the headache goes away. But one thing I just want to talk about real quick, I don't know how we are on time. How are we on time? I have plenty of time, thank you. Make me stand up here longer. Is the physical exam, because this is, you can find concussion, traumatic brain injury on the physical exam easy if you take your time. And a couple things that are important is the eye exam, and doing it slowly. Now, the typical, when you do an eye exam, they say follow my fingers, and you're doing this and this and this real fast, and you'll never see a thing if you go that fast. You really have to go slow and watch both eyes and how they're moving, because a lot of times they have what's called saccades, where it's not a smooth movement, and the eyes don't follow each other. You'll see one lag behind the other, and you're not going to see it if you go fast, but if you do it slowly, you can see it, and I see it lateral a lot, but sometimes I'll see it vertical saccades also. Another thing to do is, if you can watch the patient, have them look at your finger, put it out where they normally read, right in front of you and over to the side, and have them go back and forth as fast as possible, you'll see that they have very difficult time doing it, and it will really enhance the saccades. So you'll start seeing the eyes jumping all over the place, and it may make their headaches worse and other symptoms worse. So that's an important part. The other important is balance and movement. In the cerebellar functions from finger to nose. Again, this is one you have to watch, because a lot of times people will be able to do it, but if you watch them doing it, you'll see that it is hard. As they're going back and forth, finger to nose, they may do it smoothly, but a 15-year-old doing this, finger to nose, is not normal. And you also need to watch how they track. So doing finger to nose and keeping your finger right out in front, you'll never pick it up. But moving the finger, and I tell them, give my finger to your nose, and I'm going to move my finger, follow my finger. And as they go back and forth, and it will really bring out the difficulties you can see, especially because they're losing the communication between the right and left side of brain. When you take the right hand over into the different visual fields, you'll see a difference. So sometimes people are fine here, but when you go over here, it gets all bent out of shape. That, and then balance is important. I don't know how you guys, how do you check balance?
I do it mostly by having them walk hill to shin.
Use your microphone, please.
I do it mostly by having them walk heel to shin, heel to toe rather, and have them visually fixate on me, not on the floor. A lot of people actually get arrested for potentially driving under the influence because they're looking down at the floor,
And they can't walk straight.
Yeah, if you visually fixate on the person in front of you, or visually fixate on a distant object, it gives you a truer indication of balance.
Well, take away their ability to use their hands too. So have them put their hands on their hips, like this. One balance, have them stand on their non-dominant foot, and ask them what foot they use to kick a ball with. If they kick a ball with the right foot, have them stand on their left foot. Bring your knee up like this, and then, this is my bad foot because of my herniated disc. Having no strength, I'll have to stand on my right foot. Bring your,
out there so they can see.
can you see? I'll stand up here. So if you have them stand on their non-dominant foot, bring their hip up, their leg up here and then close their eyes. And you watch how much movement they have within 20 minutes. Most people are 20 minutes, 20 seconds. Thank you. Yeah, have them stand there for 20 minutes. How much time do I have? It's normal for people to lose their balance a little bit every once in a while, but people with concussion are going to have a very difficult time. The other thing with heel to walking, tandem gait, heel to toe, is you have to watch how they're doing it also. You know, I've seen people that are 25 and they do it, and I said, well, that's not bad for a 70-year-old. And technically, we may call it normal, but you know that an athlete who's 25 should have no problem at all back and forth with that like this. And if they're having any problems at all or any hesitation, there's an issue. So balance, movement, emotional affect is important to look at. What else can you think of that's important on the exam?
Sleep, oh.
Well, the most important is fundoscopic exam.
Oh, you're right.
And also that there is a convergence insufficient, because if they see an issue a long way, they can, but if it goes close, they cannot completely, their eyes goes around.
Right, so
and
that's
cannot
convergence.
So you have to have some even further along that, and then they're completely out. So
So it's called convergence insufficiency, is as you bring your fingers and their eyes converge, you'll see sometimes they start to converge and one eye will start floating out, or the other, or both of them float out, and I've seen some people that can't come together at all. Another thing is someone's been concussed 5 or 10 years ago, ask them if they read. Because people with saccades and convergence insufficiency have a very difficult time reading. And a lot of these people were reading books before, and then after the concussion, they haven't read in 5 years. Why not? I just don't like to read anymore. I asked them, do the words jump around on the page?
yeah. One trick that my patient taught me, they put their books up on the screen, big screen in the living room, textbooks from their studies, and read it from behind,
Right.
sit there, and 3 meters along, then they can read. But if they had a screen here and a laptop, they cannot.
Any convergence and they're done.
And so far away with the screen.
Yeah, they'll read like, you'll see a young person reading like an old person, having it out here, holding it out far from them, or they'll take a piece of paper and they read with the paper, because if they don't have that paper there, their eyes are moving up and down and they lose their place while they're reading. So those are a lot of the symptoms, those are a lot of the findings on physical exam, and you have to take your time doing those. If you're in a hurry, you'll never pick it up. Because you have to give them enough time to show what the problem is. Let's talk about anything else you can think of. Neck exam's important also. Treatment. When we talk about it, I think the general consensus is you treat this as the headache presents, whatever the phenotype of the headache is. We haven't had there's not a whole lot of evidence, and I'm not sure what year these are. You put the names down, but not what year. What is your go-to in treating headache or post-traumatic headache?
I usually start them on a tricyclic, amitriptyline at bedtime.
And there is some data with that.
Yeah, it tends to shorten the duration of concussive syndrome. I think that's pretty well established.
It may
Also,
help with a sleep disorder.
I was just going to say that many of these patients have difficulty sleeping at night, and so that can help sleep maintenance with a tricyclic antidepressant.
I do the same, nortriptyline, amitriptyline as the first drug of choice. If there's much migraine, I could add candacetan. It's much better than topiramate. Candacetan to take these down, and then a little bit, 20 milligrams of amitriptyline. This combination, topiramate, they don't tolerate it in our hands because they have all the cognitive side effects. On top of that,
I've had some success with it.
yeah, but it's
It's not the first line.
It's not the first line, no.
I have a little bit of a different approach. I basically just treat whatever the underlying phenotype is, and what other comorbidities they have. I love amitriptyline also in people who are having trouble sleeping, but unfortunately, even though New York is not as fat as Mississippi or West Virginia, we still have a big problem. Big problem. Yes, I did. I'm learning from you. It's, well, you know, it's whatever comorbidities that have that very often determine what your approach is going to be. And I just have, you know, I know Larry Newman very well, and I remember the study that he and Christine Lay did showing that indomethacin is very good for these. The problem with indomethacin, of course, is patients don't tolerate it well because of all the GI issues associated with it. But I've had a lot of luck using that combination of a tricyclic and a non-steroidal, particularly indomethacin on some of these people.
Now,
Personal
another
experience, no studies.
Another thing outside of medicine is therapy.
Yeah, I was just gonna say.
And you know, there's, again, there are no studies on what people call vestibular therapy. I hesitate to call it. It's more balanced therapy, eye therapy. But a lot of people, a lot of their headaches will get better once they go through therapy, and they retrain their brain to start working together. They get their balance better. They can get their vision better, and you can do vision therapy also. I will warn you about the vision therapy places that use computer only. If you use computer only, you'll see exactly what you were talking about. Instead of sitting here and doing it, you'll see that person will be back a meter from the screen and have their head tilted to the side, because that's the only way that they can read without everything jumping all over the place. And in order for vision therapy to work, they have to be at the right spot. And they'll learn how to track. So they have to relearn how to track things also. So therapy is important.
We did a study with our psychologist as well with the group therapy, the cognitive behavioral therapy, because and randomized them to either control with a waiting list and to group therapy, 80 patient, 85 patient or something like that, balanced, and they completed it for 6 months with 9 group lectures, and they were very happy about it. But at the end of the day, the waiting group, the control group did better than the TBI group in the group therapy. So we still use that counseling with the psychologist and how to manage your energy and general treatment that we give to also migraine patients, but specific group therapy to a group of patients with concussion. Maybe it was too late. It was 1-2 years after, because they were not referred to the headache center. If we had it earlier, it may have had an effect, but it was depressing to see that. So we're not doing it for specific for traumatic headaches any longer.
Well, let me ask this, because it's a question that comes up, is when do you start therapy? Yeah. Now, I will tell you that I see patients after they have already gone through the 2 or 3 concussion centers in Pittsburgh. And I'll see them at 6 months or a year. But if you see somebody acutely, how long do they rest, and how long until you get them up and moving and into therapy?
I rarely see anybody that acutely, but I can tell you what I used to always recommend, and that got me into trouble with coaches, was 2 weeks of rest, no no contact sports at all. But now that I usually see people 6 months or 12 months or a few years after the onset, I don't have an answer for that. I just try to treat them with what we see at the time that they're being evaluated, and recognizing that it's a secondary effect, a secondary worsening of what was usually a pre-existing disorder, particularly migraine. I rarely see anybody who comes in with very frequent post-traumatic headaches who didn't have, pre-existing migraine or some other headache disorder, with one exception, and that's former military. And even those, the worst ones, are the ones who had a mild traumatic brain injury, not a serious one, and it just exacerbated their pre-existing migraine. And I know I have a biased experience.
It's a selected population that we see in the specialized. We cannot generalize because we see them 1 to 2 years after they had it. So we don't see them. Those we should study is those that do not have developed the headache. That's my goal, to have them in the early stage and follow a huge cohort over 1 year, see what is their phenotype, what is their genotype, and what happened to those that do not, they have exactly the same trauma. But that would be wonderful to do, and also those that never had a headache before.
You know, I reckon this might be an interesting study for the VA to do on people who are exposed to blast injuries, you know, in theater. What's the difference between the ones who do develop the post-traumatic headaches and the ones who never develop a headache at all? Have you noticed much of a difference in returning vets?
It's difficult to say because they're so far away from the original injury by the time we see them. At the Academy meeting, I don't remember exactly when it was, 5, 6 years ago, there was a presentation by a couple of Army neurologists on post-concussive headache, post-concussive syndrome. It was a paradigm shift for the DoD because previously, you know, I mean, they got all kinds of specialists in the armed services that are seeing patients. But if you get deployed, you're a generalist, flight surgeon, you know. This is the first time that they actually sent neurologists out to the field to be neurologists, and they were focused on the folks with head injuries. And they had collected a bunch of data about all these things. And I remember, because one of the questions was, how do you separate PTSD from post-traumatic TBI headache? For them, it was headache. If they didn't have headache, then it wasn't TBI. If they had headache, it was TBI.
Oh, they'll miss
Now,
some.
I don't know exactly, because it's in the cobwebs, you know, why they reached that conclusion, but it really struck me as a pretty significant finding.
I think Alan Finkelstein's doing work in that still. Finkel. I added, it's Finkelstein, Goldbergstein. Yes. Alan Finkel. There is data to show getting people up and moving faster within 3 to 5 days, they do better. Usually if I see someone acute, it's 3 days rest and then they need to start moving, get them into therapy. You know, when do you start medications for headache? You know, I just use acute medications in the first couple of weeks, and then if it looks like it's going on longer, then we're going to go to preventive.
Yeah, that's a great point. That, you know,
They turned off your mic for a reason. There you go.
Is
Is it on
Is
now?
it back on? You know, again, I often see these people months or years later, and very few of them were ever treated with a preventive medication or a non-steroidal that can, you know, go back and forth between acute and preventive uses. Would it make a big difference if we put these people on some type of preventive or long-term acute therapy, starting out almost immediately after they've had a significant head injury? Would it reduce the post-traumatic headache? Would it reduce the cognitive dysfunction? Yeah, I don't know how to even design such a study. It would be very, very difficult to control it, but it certainly is information we need to have.
Okay. I think we covered, I don't know what else is here, and I know we're running out of time. What? Yeah.
Okay, this is a little bit off track, but we see a lot of young girls with concussions from a silicone and get thrown in their head or hit their head when they stood up under the table. How do you call bullshit without being direct?
You know, if they're if you can't find any, you know, I believe them outright, and then the time will tell. But usually, like I said, there's abnormalities on physical exam. It's hard, you can't fake saccades. You know, you can't fake it. And
They've clearly read, you know, Googled it,
Yeah, I just hesitate because I talk about this a lot. I've lectured to school nurses who are notoriously horrible with migraine, and they think they know something about concussion, but they don't. And it's very, and I really try to steer them away from, I think that these people declare themselves at some point in time. Sometimes you know it right up front, but they'll declare themselves, and I give people the benefit of the doubt up front because you just don't know. And I've seen people with what seem to be very minor head trauma have a very major problem, and it happens. It happens, and I think give them the benefit of the doubt first, and they'll declare themselves over a couple weeks.
I don't know how best to ask this question, because you don't have to bang your head to have a concussion. But how hard do you have to bang your head?
I don't know. So let's try that.
I attended a meeting
I can do it this hard?
long ago, when I was interested in computerized analysis of EEG. And of course, Irvine is sitting right on the freeway, Southern California, rush hour traffic, bumper to bumper, frequent fender benders, low velocity impacts. And frequently people come and get taken to the hospital, local ER, Irvine's right there. So they had lots of these patients that were coming in. Some of them because they wanted to. Many of them were dragged there by the police because of the fender bender. And of course they were interested in quantitative EEG, so they were doing quantitative EEGs on these people. And there were lots of people, many of them developed post-traumatic headache, that really didn't have a significant head injury. It was probably a little whiplash, but they really didn't have any neck pain. They didn't want to be there, but their quantitative EEG was abnormal. So something happened, and it wasn't a very significant trauma. And so I think you need to be very careful, because it doesn't take much.
Yeah.
It just takes the right angles.
Yeah, that's very interesting, because I think all of us we see biased populations. And I would second what you're saying. I rarely see anybody who had a serious brain injury in my office complaining of headaches.
Right.
Okay? And it's almost the ones who have what seem to be the most trivial head injuries who come in with the most refractory headache disorders. And it's an interesting phenomena that I really just don't understand. I assume you see something similar.
Exactly. That has also been studies, I cannot recall the names, that is nearly inversely. Of course, there are many more mild than there are severe and moderate, but there's also inversely in relation. It's inversely related to the severity. So maybe there has been theories said that you are aware that something happened to you, so you are alert. And this alert gives you a stress that can do this. When you have a severe, you are unconscious from 0.0. So maybe there's also something about this alert, this stress reaction you have in the moment. You see the car come, boom, boom, but you are awake. Maybe it's a theory. I don't know how to prove it, but it is exactly a very mild injury, and they are disabled for years. It doesn't make sense in our neurological practice, but it is.
I think for patients with really profound symptoms over what may be presumed a really minor impact, it's a good time to ask about previous possible injuries. One of my most refractory patients he's completely disabled. What disabled him was he was cleaning around the house in the backyard, and he was under the kids' trampoline, and he stood up and he hit the back of his head on the top of the trampoline. Didn't even see stars. He just didn't feel very good. But he was in Afghanistan, and he was a paratrooper, and he had no known, he tells me he had no injury, but he was in Afghanistan, and he was infantry. So he was around those blast injuries, and this little tiny thing bumping his head in the backyard, he is completely disabled. He's 42 years old. So it might be a good time to ask about what had happened in the past, any previous injury, because second impact syndrome is, I mean, that's what we're dealing with.
Any other questions? Yeah. You want, someone take this around? Okay.
So I don't know if you guys have seen this, but I actually just found out about this video that was made by like an NFL player who had repeated concussions, and it just totally changed him. He didn't want to live anymore. He didn't like his life. He was rich. I don't know if you guys have seen it. It's a documentary. But my question is, how many, brain injury, whatever, trauma, concussions does it take before you kind of get this like irreversible damage where it just totally changes who you are, you're totally disabled, and there's really nothing you can do?
You like
It can
asking
be
questions
one.
that are not answerable.
Can be.
We don't know. It's not known at all. For some people, it's one. It's what your brain makeup.
It's also-
some people it's one, some people it's two, some people it's six.
It's also the timing in between the two. The shorter the time span between impact number 2 from impact number 1 is, 1 and 1 makes 5. So
Also has to do with what your genetic predisposition is. I saw a fascinating two brothers. They were twins. They were fraternal twins, not identical twins. One played guard, one played tackle, all the way through high school and college together. And if you're an offensive lineman, you're getting hit in the head or neck on every single play. One had really disabling chronic migraine, and the other never had a headache in his whole life. Mm-hmm. So I think the difference has got to be, there's got to be some genetic predisposition that we at this time have no way of determining who's at the highest risk for it. And these were two people who literally, they were side by side on the offensive line all the way through high school and college. One has disabling headaches, the other's got none.
The other thing I wanted to say was there was just a study published with indication that the KIAA 0319 gene is more likely to cause people to have concussions.
Yeah, I saw that. I saw that also. I didn't get a chance to read the study.
Well, basically what they did is they took like a bunch of Division I football players, and they actually found that there's a gene, and one variant can cause you to be more likely to get a concussion, and the opposite variant gives you an increased risk for dyslexia. And, with genetic testing coming and like really being the future of medicine, I think it's probably not too far off that we could probably test these people and figure out, okay, what is the
You should not play
likelihood
football.
that you're going to have another concussion? Like, what is your risk? Like, you don't want to end up like, this guy who didn't want to live anymore because he had so many concussions it changed his brain.
Well, it's been well publicized if you follow football about Antonio Brown, and as a Steeler fan my whole life, to watch the demise of him, and I really, he's been difficult. He's had a personality disorder from the get-go, but to see what happened over time, there's no doubt that he has CTE. His behavior has gone so far off the wall. And I really believe he's CTE, but he'll never get treatment for it. He's functional enough to escape treatment. And who knows what his headaches are. I don't know. Maybe he has none, but I bet he does. Another
Ashley
question?
has a question.
Yeah.
It's a two-part question. So regarding micro concussions, when cluster patients hit ourselves on the head, are we giving ourselves micro concussions? And then when patients go on to develop another condition like migraine, could that be the cause?
I don't know.
My knee-jerk reaction is yes. I mean, it takes very little to, there's no micro concussion or grade whatever. Concussion is concussion. So, if you're initiating those forces on your head, then yes, absolutely. I think that's entirely possible.
Well, but I think the point is we see head trauma in people that don't have a frank concussion, but later on develop CTE and develop other concussion-like symptoms. Does doing this cause that? And I don't know. These football players, I think it was, they're banging their heads all the time, and I think it was Lee Goldstein out of Boston, who I talked to, did a study looking at cognitive function of football players at the beginning of the season and as the season went on, and anybody that had a frank concussion was taken out. And he saw a cognitive decline through the entire season. And then at the next season, they recovered, but they never recovered to where they were before. So every season there was less and less, it was lower and lower. And that's a concern, but these guys are hitting themselves with much harder force than doing this. But if you're prone to it, who knows? I don't know.
For psychiatric patients in adolescents, we put them in helmets for head banging behavior for a reason, right? So, I mean, that's a compulsive thing that certain psychiatric disorders have, so, yeah.
Anyone else?
This is probably just as much a comment as it is maybe a question on your guys' experience, but I have been starting to work. I have a wonderful occupational therapist that I work with, and she has been doing a lot of neurofeedback in the head injuries, and I've been using it more and more with development in my headache clinic. And I'm really getting some quite remarkable results, in addition to some of the more medical treatment with physical therapy, vestibular rehab, or some of the medications. So common and
Neurofeedback, is it the same as biofeedback?
It's a little different. So biofeedback uses more EMG type technology. The neurofeedback is more EEG based, and it's about regulation and retraining of the brain waves.
Well, I know in migraine, EMG biofeedback's been shown to be effective, but I don't know any study. Do you know any studies with EEG biofeedback? No.
I know there's some studies out there. It's not robust.
There's nothing robust in this.
Yeah, it's not robust, but in my mind, I've had a lot of anecdotal improvements in my headache and brain injury patients, and there's no side effects. Like Heather was saying with the stimulation devices, you literally have nothing to lose because nothing bad will happen to you as a result of this treatment. And we've actually had some really good luck getting insurance approval with it.
I think whatever has no side effects is worth trying. And you can see the list of non-oral treatments here on this slide. I've personally have had a lot of luck with using onabotulinum toxin on a lot of these people who have, headaches, because almost all of them phenotypically look like chronic migraine.
I have two, and I wish I would have tracked them all, and I didn't track them all.
Yeah. The other thing was, and we're literally just starting to try it now, is with the new CGRP monoclonal antibodies. Again, the side effect profile is so good that if the other stuff hasn't worked, why not try it if phenotypically they've got a migraine feature to their headaches? How about you?
There are ongoing studies on the antibodies now. Maybe you have the same impression, but when you put these patients on a regular migraine prophylactics, they're more sensitive than others. Have you seen the same? I have not seen it documented, but it's my feeling I have to go very, very slow to pyramid, beta blocker. Why are they more sensitive? Men, women, doesn't matter. They do not tolerate anything, and that's why it's so important with non-pharmacological. And my regular migraine patients, they can tolerate 200 milligrams. Doesn't matter. What's going on there?
Not in this country.
No, a lot of my migraine patients can't tolerate, don't tolerate it well either.
We know it from day one that you have to go very slow with them, because maybe it's the cognitive side effects or what is it, but they have to be very, very careful with them.
I agree with absolutely. I mean, I've often had patients tell me, it's not that the medicine you gave me wasn't working, it was helping my headache. I just can't stand it.
Exactly.
Exactly.
But really, the traumatic brain injury really jacks their nervous system up to another level.
Yeah, they must be.
Any other questions? This is our full question and answer. You have one?
Yes. I take care of a lot of ex-military patients, and a lot of them have been wounded in combat, and I'm seeing them what's unusual, because I've read about the history of military injuries, is in the most recent conflict, there's a lot more women that are injured in combat now, or involved in combat, particularly IEDs and vehicular damage and the like. With almost without fail, women soldiers seem to be much worse off after these injuries than the men are. I mean, it's just something I see quite a bit of.
I'd have to ask Alan Finkelbergstein about that. I don't know the data on it. I think, I bet he has the information. Yeah.
One big difference is that many of the men have been injured in infantry combat, whereas many of the women soldiers were involved in vehicular movement and then very large explosions nearby. I mean, it would be strange to say, you know, you wouldn't be as prone to traumatic brain injury in close combat as you would be just riding on the road.
I think that
50 kilograms of explosives.
I think the point you just mentioned is the blast injuries are, from what I've heard and what I've seen, is blast injuries are much more likely to produce prolonged post-traumatic headache and other symptoms than direct trauma does.
Body armor
Yeah.
and helmets do not seem
Yeah,
to
no. No, and I don't think helmets are very protective in football or hockey either.
No, they're trying to make helmets that absorb
yeah.
the blow more to keep the head from bouncing around, but I don't know if any of them have ever proven to be effective. Yes, Chris?
Somebody made the point years ago that if you think about football players 50 years ago wearing leather helmets and pads and who weighed maybe 200 pounds, that there was a lot less of this trouble because no one in their right mind would smash head on into another person's head with leather. But now that you have this huge apparatus that makes you think that you're safer, and both of you weigh over 300 pounds, the kind of trauma that is being inflicted on a daily basis is nothing.
That's a great point, Chris.
You're absolutely right. I mean, I've heard people say we need to go back to leather helmets, but you see, that doesn't make as much money. They want to see people collide, because if you think the NFL owners give a crap about their players, you got to get your head out of the sand.
Yeah, Chris, I grew up in an era where we played hockey without a helmet. Nobody wore a helmet unless you already had a serious, traumatic brain injury. And I don't recall, very many of my friends or teammates complaining of post-traumatic headaches because we didn't have that many head injuries. Had some facial injuries, had a lot of neck and back injuries, but it's true. People are less careful when they think they're being protected by these helmets that really don't work that great. I have one of my chronic migraine patients happens to be a women's lacrosse coach. And I asked her, why aren't high school lacrosse women wearing helmets, whereas the boys do? And she said, because we think the helmets cause more problems than they're worth. And I think that's a great point. It's
And that same guy, Lee Goldstein, that you mentioned, one of the lines of research he's done is studying rodents using glass tubes. So you have a little mouse at one end of the tube and you have an explosion at the other end, so it transmits a shock wave. And he tried at first all kinds of body armor and big helmety things. How do you protect this thing? None of it really did any good. And then he figured out that if you just protect the neck, if you just prevent wobble, that you have a dramatic.
Right, and he just used a cable tie, and he put the cable tie around their neck and fixed it to the apparatus, and then they gave him the blast, and they didn't have any trauma. It just to keep the head from bouncing around after trauma. So Christina, I think you're on now.
Oh, good.
Wanna
I was
Thank
hoping- I was
everybody.
trying
Thank
to
you very
sneak in.
much.
Anyway.
Thank you for throwing us into this